Hello everyone, my name is Takao Kanemitsu from Fukuoka University Chikushi Hospital. Today I would like to outline the characteristic endoscopic findings according to Helicobacter pylori infection status. This is a report by Uemura published in New England Journal of Medicine in 2001. In this paper, the result showed that gastric cancer occurred in HB-positive patients and didn't occur in HB-negative patients. Next, this is the result of prospective randomized controlled trial in South Korea published in 2018. The study included 470 patients who had undergone endoscopic resection for early gastric cancer and were treated with either HB-eradicated drugs or placebo and followed upon their progress. As a result, the HB irradiation group was found to be about 50% less likely to develop ectopic multiple carcinomas than the placebo group. Therefore, it is very important to accurately diagnose and eliminate HB infection. A report of the survey conducted among endoscopists around the world regarding the diagnosis of gastritis is presented. While endoscopists in Japan and Korea rarely perform biopsies for the diagnosis of gastritis, about 40% of endoscopists in other countries answered that they perform more than 5 biopsies per case. Thus, Japanese endoscopists place great importance on observing the condition of gastritis closely. Today, I would like to introduce to you all Kyoto classification of gastritis, which is classification for observing gastritis, endoscopic diagnosis of gastritis, and its significance was discussed at the annual meeting of the Japanese Society of Gastroenterology held in Kyoto, 2013. The objective, simple, and clinically significant findings of gastritis are clarified based on the diagnosis of H. pylori infection and the risk assessment of gastric cancer. In Kyoto classification, HP is divided into current infected, past infected, and uninfected, and the endoscopic findings are specially explained. Let's start with the finding of the current infection. The first notable feature is diffuse redness, which is observed in the non-atrophic mucosa of the gastric body. This redness is closely correlated with the degree of neutrophilic and mononuclear cell infiltration caused by Helicobacter pylori infection. The observations of diffuse redness are especially prominent at the boundary between the gastric proper and pyloric gland regions. This characteristic serves as a significant indicator providing variable insights into the inflammatory response and infection-related change in the gastric mucosa. Here is a typical example. Diffuse redness is noticeable on the body, and the body is severely atrophic. Xanthomas are also seen. A faded elevated lesion 10 mm in size is seen on the posterior wall of the antrum. The interior of the lesion is irregularly depressed. Pathological diagnosis: early gastric cancer, 0-2A plus 2C. Following diffuse redness, another significant Helicobacter pylori infection finding is mucosal swelling. This is identified as a soft, second mucosa in the gastric body indicative of inflammatory cell infiltration and edema triggered by HB infection. The recognition of mucosal swelling is further facilitated by spraying with indigo carmine, aiding in a more accurate determination of the characteristic feature. A typical case is presented below. Reddening and swelling of the mucous membrane is seen on the gastric body. A large ulcerative lesion is seen in the gastric angle. A wide ulcerative lesion is also seen in the upper body. In addition to these, small ulcers are observed in large numbers. Finding of the edge of the lesion shows no evidence of cancer in magnifying endoscopy with NBI. The pathological diagnosis of this multiple lesion is marked lymphoma. Sticky, adherent, dense mucus is a typical finding of HB-present infection. The mucus, which is a breeding ground for HB, found mainly in the greater curvature of the body. Interestingly, HB disappears when the stomach is endoscopically washed too often. This is an HE stain image of the gastric biopsy. A closer look at the mucus reveals the presence of numerous HBs. Thus, when performing HB culture or HB spectroscopy, it is recommended to aim for cloudy mucus to obtain a specimen. Nodularity is then explained. Nodularity is the appearance of a dense cluster of uniform, whitish granular bumps. Pathologically, it is a proliferation of lymph follicles serving primary site of gastric carcinoma in young patients, especially undifferentiated gastric carcinoma. It is easily observed not only in the antrum but also in the cardia. This is a typical case. Sticky, adherent, dense mucus is prominent on the body. The antrum shows marked nodularity. This is what it looks like under magnification. Nodularity are seen not only in the antrum but also at the esophagogastric junction and at the cardia. This case is 36 years old female. Atrophy is observed in the body. This nodularity is observed in the antrum. An indistinct faded area is seen in the lower gastric body. The arrows indicate the localization of the lesion. The pathologic diagnosis of this lesion was undifferentiated early gastric cancer. The last finding of the current infection is an enlarged fold, tortuous fold. The body folds are thick and tortuous and don't disappear on air exchange. It is reported to be a risk factor for undifferentiated carcinoma. A typical case is presented. A large amount of air is pumped into the stomach. However, the gastric folds are not stretched and are tortuous. 0-2A plus 2C is observed in the gastric body. The lesion was a differentiated early gastric cancer. The findings of past infection are then presented. Atrophy and intestinal metaplasia can be observed in both current and past infected patients. However, generally, These findings are often more easily identified in individuals who have previously been infected than in those currently in an infected state. One of the characteristic findings in individuals past infected with HP is the presence of map-like redness. These findings appearing in the gastric environment after HP eradication. Histologically, they are intestinal metaplasia. The size and morphology vary, as does the degree of erythema. There are scattered red and depressed areas in the antrum. Each of them appears like small erosions. However, there is no blood on the surface, and the patterns of the mucosa can be observed clearly. It is a typical mucosa with intestinal metaplasia. This is a pathological finding of a biopsy. It shows complete intestinal metaplasia. This is another case. An erythematous depression is seen of the upper part of the body. This yellow flame is observed under NBI magnification. A well-defined microvascular pattern and microsurface pattern can be observed, and a non-cancerous diagnosis can be made. Histologically corresponding to the endoscopic findings, it was intestinal metaplasia. On the other hand, observing other parts of the depression, cancer can be diagnosed by the presence of an irregular microvascular pattern inside the depression. Histological image corresponding to the endoscopic image. This is the finding of differentiated adenocarcinoma. Thus, cancer may be present inside the map-like redness. Next, we discuss atrophy, which can be observed in both past and current infections. The results are judged by the transparency of the blood vessels and the change in white tone. Histologically, it refers to a decrease in the number of gastric glands. A typical case is presented here. The gastric body and antrum are markedly atrophic. As you know, the gastric body port is the last area to atrophy. Therefore, in most cases, non-atrophic mucosa is often seen in the great curvature of the lower gastric body. If there is a case in which this area is completely atrophic, it may be a terminal stage of autoimmune gastritis. The final finding in past infection is intestinal metaplasia. This is also observed in both current and past infected patients, but is more clearly visualized in past infected patients. It is observed as a grayish-white mucosa centered in the area of mucosal atrophy. As you can see, image-enhanced endoscopic observation is more diagnostic than white light observation. Histologically, almost these mucosa are incomplete intestinal metaplasia. Typical case: multiple grayish-white mucosae are observed in the antrum. In MNBR, white opaque substance can be seen clearly. Here are two markers of intestinal metaplasia that can be visualized by NBI. These are light blue crest and white opaque substance. The images are magnified but can be visualized without magnification. I will present 3 HP uninfected findings. The first indicator we consider is the regular arrangement of collecting venules, LAC, a highly variable marker for HB-infected stomachs. The lac is assessed in the lower portion of gastric body or angle. As can be seen, starfish-like aggregate venules are observed. First, the endoscopy is moved inward to observe lesser curvature. Observe the upper part of the body, then the middle part, and finally the lower part. It is sometimes difficult to determine whether the antrum area alone is atrophic or not. Even in such cases, if the presence of lac near the gastric angle can be confirmed, it can be determined that the stomach is uninfected. Fundy gland polyp is a well-known uninfected finding arising in the fundy gland region of the stomach. Histologically, it is characterized by hyperplasia of the fundy glands and cystic dilatation. Endoscopic image of the uninfected stomach of a 40-year-old woman. In white-light imaging, this appears as smooth, slightly transparent polyp. In NBI, this is seen with round crypt opening and dilated cyanide vessels. The last finding is a red streak. It is a longitudinal band of erythema running longitudinally along the long axis of the stomach, with several parallel stripes. It may be accompanied by erosions of hematin deposit. Red streak is cause a congestion of microvessels in the superficial layer of the mucosa. This erythematous polyp is seen in HP uninfected stomach with red streak and FCP. The surrounding area is evident as HP uninfected mucosa. In MNBI, both microvascular pattern and microsurface pattern is not irregular. However, the pathological diagnosis was early gastric cancer. In recent years, the number of uninfected people with HP has been increasing in Japan. Similarly, cancers that gradually develop in uninfected stomachs have also been found. Today, I have outlined endoscopic findings in the stomach associated with HP infection status. I hope this presentation will be useful for your practice from tomorrow. Thank you for your attention.